Hey everybody, so here we are to discuss management of opiate overdoses and prioritization of the appropriate treatment. So the scenario that was given to you was you're dispatched to a unknown age male who was just found unresponsive in the middle of a field. Completely unresponsive, GCS of 111, believed to be an opiate overdose of some sort with pinpoint pupils, barely breathing, very shallow respirations, and obvious hypoventilation as pictured here. All other vitals checked out, so the differential diagnosis just went ahead and straight into that opiate overdose. So the question was kind of posed of what do we do first? Do we want to go with giving Narcan first, or do we begin with bag valve mask ventilations? So as I saw all the comments on Facebook led into, yes, the appropriate choice is to begin ventilations correcting those airway issues first and foremost. So the effects of, or the reason why we need to be doing that. So why we don't need to go to Narcan directly and why we're going directly to ventilation is all the other harmful things that can begin by that patient not having their airway corrected. They could suffer aspiration, they could have an anoxic brain injury from their brain remaining hypoxic for a long time. And you give them that Narcan, they can come back and be very combative from that altered mental status due to hypoxia or hypercarbia states. Also, a rarity, but something we're definitely going to discuss, is flash pulmonary edema. Okay, so think about all these things. If we aren't managing the airway as we're taught of airway breathing circulation, of those harmful effects that can come from that patient hypoventilating. So to understand this non-cardiogenic pulmonary edema, this flash pulmonary edema, as I said before, it's a rare instance, but there are many cases of it happening, and here's why. So if we give Narcan, that creates a sympathetic response in the body. So a little bit of Narcan, a little bit of sympathetic response. A lot of Narcan, a bigger sympathetic response. So some studies have shown of all the details here that in plasma there was a 30-fold increase in epinephrine in that plasma following high dose of Narcan injections. Showed a cardiac index increase by 74%, stroke volume increase by 44%, an increase in systolic blood pressure and pulse pressure. And all this, even showing studies in mice and lab rats to be even more exponentially increased in states of hypercarbia. So if that patient is hypoventilating, that CO2 is going to build up. So they will be in that hypercarbic state. So you can see here by Narcan being administered, they're going into a sympathetic response, increasing contractility, all of the catecholamines being released, increasing that pure sympathetic response. So the breakdown of what's happening here. So if we look at our alveoli, and we understand that the blood coming through does our gas exchange, CO2 offloads, O2 onloads, and it transports and continues on around. But what happens in this is if that patient's hypoventilating, within the alveoli is a lower pressure system. And now when we have that large sympathetic response, the vascular side becomes the higher pressure side. So just like in other states of, pulmonary edema, if you have leaky capillaries, it leaks out into the alveoli. So what's happening here is we've got the state of a low pressure, no PEEP being in there, the patient's not maintaining their own airway adequately. So we've got a low pressure and then a big sympathetic response on the vascular side, pressurizes this side and can make these capillaries leaky. Okay, so now, and some of this is shown higher instances in patients who have other underlying health issues other than, substance abuse issues. But if we start correcting ventilations, we restore PEEP pressure, we're maintaining a good pressure gradient inside the lungs. So then whenever Narcan is given at an appropriate dosing, we don't have such a huge different shifting here of a pressure gradient causing such a high and low pressure. The other theory on this is in these instances, when that patient starts taking that first breath, this negative pressure side becomes even more of a negative when they take the it's almost like they suck more air out of their body when they're trying to inhale and exhale without this being restored properly, like a large volume shift. Okay, so, and again, a lot of these are theorized. They're showing these, and that's what the all the research is alluding to of the reasoning behind this is mostly due to this pressure issue of sympathetic on that high vascular side, creating a whole lot of epi norepi being released in here. Lots of pressure vascular side, low pressure on the volume side. So we ventilate, restore peak pressure, keep those alveoli inflated, preventing the atelectasis, and continuing having a more even pressure gradient. So now it goes to the next question of which route is best. So we have intranasal, intramuscular, and intravenous methods we can do, as pictured here. There's even ones coming out now in auto injectors, intended more for lay persons. Okay, so intranasal, we've got two different routes here of using, attaching an atomizer to a syringe or the pre-filled canisters. Now, these are mostly designed for laypersons or initial first responders, such as this is very common to be carried by law enforcement or what is being given out by prescription or over the counter or whatnot. So these are very easy to give. And it can also come in higher doses. You're seeing these now starting to come in 4, sometimes even 8 milligrams in these big packages, and also in different concentrations. And it varies from country to country of what they're using. So the pros of this, they're super easy to use. So it takes very minimal training to be able to give these appropriately. And also a good pro is no exposure to bloodborne pathogens. But some cons. It does have the slowest onset of reversing that opiate overdose, and there could be some absorption delays, such as if a patient has epistaxis, that nosebleed, they have excessive mucus production within their nose, or they're using other drugs like cocaine. So commonly, maybe not necessarily super common, but there is a concept called a speedball where they will do cocaine and heroin together. So when they snort cocaine, it causes vasoconstriction in their nose, dries up everything, and doesn't allow Narcan to metabolize or absorb in those mucous membranes appropriately. And then when in the injection route, so injection mostly targeted towards healthcare personnel, giving that intramuscularly or giving it intravenously. The pros of that, just a little bit more training, pretty basic training to be able to give an intramuscular injection. We have more of a controlled dose, so we can generally measure it out, whereas in the like the pre-filled intranasal canisters, it's pretty much all or nothing. So in this, we can measure things out, control the dose, control the administration flow a little bit easier, and it's got a quicker onset intramuscularly and an even quicker onset intravenously. Now, some cons. To do it intravenously, that is more advanced training. So it's a little bit more in depth. That's at the ALS level, learning how to start IVs, adapters, and everything goes with that. Also, bloodborne exposures. So we're accessing the blood pathways of these patients. Earlier studies were showing from the early 2000s that something like 80% of IV substance abusers also had hepatitis C. Now we know as time has went on, that's not necessarily as trending anymore as it once was, but still that high risk of bloodborne pathogen exposure. And then also kind of quick onset IV. So I put that in there just because sometimes that onset can be too quick. That sudden, huge sympathetic response can be too much on that patient. So ultimately, where are we going with this? Which one is better? So breaking all these down from what a lot of research is telling us is intranasally around, depending which research is out there, around 70 to 80% of the patients every time, it works every time. So 70% of the time, It works every time. But that does that other 20 to 30% is meaning that they're needing reoccurring doses. They need a second dose of intranasal, or they're having to go to an alternative route such as intramuscular or intravenous. So IM, it's more accurate administration, generally does not require any second dosing. So while 70 or 20, 30% of intranasal requires a second dose, it was something a lot of research around 3 to 5% of intramuscular would require a second dosing. And then intravenous, quick, but maybe that's too quick. Okay, and all these are based on dosing of zero point 0.4 to 2 milligrams. And there's a lot of research going out between these of different concentrations. Like a study in the UK was doing intranasal at 1.4 milligrams and zero point 0.1 ml. So a super concentrated dose. And in those same areas, they were going to a higher concentration of Narcan over a larger volume. Okay, so in some of these two things to think about. Intramuscularly, if we're going with the standard concentration of Narcan, that's going to put our 2 milligram dose, excuse me, at 2 milliliters. So we got to think about muscle groups there too, and the size of the patient, where 2 milliliters on a very small, frail person might be too much for the deltoid. You may have to go to a larger muscle group, or 1 milliliter in the right delt, another milliliter in the left delt. Okay. So some comparisons between those. But inevitably, intranasal works, it's efficient. It works well. Intramuscularly works really well. And then a lot of studies kind of going that maybe IV's working too quick. But IV's most definitely best at that smaller dose. So a lot of stuff IV's kind of around that given zero point 0.4 at a time, intramuscularly around 1 milligram at a time, intranasal at generally around 2 milligrams at a time, just due to bioavailability, the onset, duration of how quick it goes in. So one thing we need to think about here is the too quick onset in that IV. Okay, so what we could be happening here is too quick that onset, a huge sympathetic response, and that's a lot of times when that large dose of IV Narcan's been slammed, the patient suddenly wakes up and starts projectile vomiting just from all those catecholamines being released, that huge epi, norepi being dumped in her body, all the gastric motility, and now we're causing even more issues in these patients. Okay, so intranasal, pretty safe, straightforward, works 70-80% of the time on the first dose. IM, very safe, can be used across almost every level of healthcare personnel. My personal favorite intramuscularly, and then IV. If we think about time delay between starting that IV and when we can be given that intramuscular injection, and then also more bloodborne pathogens of directly accessing vein. Okay, so just as a reminder, you can go to Master Your Medics and begin your free 3-day trial. So this has been, I'll see you all in the next one.